Good afternoon, everyone. Welcome to this talk titled Suicide and Self-Harm in Singapore. My name is Jared. I'm a psychiatrist working at the Institute of Mental Health Emergency Services. This afternoon, I'll be sharing with you some of my readings, my experience dealing with suicidal patients, and some of my thoughts about this topic. I may not necessarily represent the views of MOH and IMH, and maybe some parts you shouldn't quote me because I do get carried away when I give this talk. This is not a clinical talk. In the audience, we have got very learned people with a lot of experiences with this topic as well, so I'm really looking forward to the Q&A at the end of this session. Suicide is a wicked problem. We may have seen this term nowadays, but what exactly is a wicked problem? It is a problem that is difficult or impossible to solve because of its complexity and interconnectedness. And you can imagine why suicide is a wicked problem. It is not a Singapore problem. I think the world is facing this suicide described as a public health crisis. Almost 800,000 people die due to suicide every year. And this works out to be roughly one suicide in the world every 40 seconds. Even though there's so many suicides, every single one of them is a tragedy. One recent US study suggested that for every one suicide, more than 130 people are affected emotionally, psychologically. So you can imagine the impact of suicides in the world in Singapore. SOS just published their data for 2021 recently, in July actually, and it showed that actually suicide numbers in Singapore, the total numbers have dropped from 452 the year before to 378, but the number of youth suicides climbed up. 378. If you look at this, every year the number hovers around 400. We almost always have 400 suicides a year in Singapore. If I were to ask you to guess about the number in 2022, as long as you say a number around 400, you won't be that far off. And of course, I hope this doesn't come and bite me next year when suicide numbers are released. But our suicide rate is dropping. We have a consistent numerator, 400, about there. But our population is increasing. So our suicide rate actually is dropping, and across the age group as well. Can we ever eradicate suicide from our society? Probably not. This Frenchman, of course, there's a lot of criticism about his book and about his study, research methods, and so on and so forth. But he predicted that there will be an increase in suicide during periods of major life or social changes. And this was published in the 1800s. Is there a time in our history where there will be no life or social changes? We are still in the midst of a pandemic, and all of us witnessed the effect that had on us, on the world. Durkheim also mentioned this, not in these words, but he mentioned this, that the more socially integrated and connected a person is, the less likely he or she is to commit suicide. And I think from clinical experience, I can tell you that this is true. I see patients in the emergency room who are suicidal, and many of them are socially isolated or disconnected from their family, from the community. An even more wicked problem then is youth suicide. I'm not sure how many of you in the audience are parents with young kids. I'm not sure how you react emotionally or psychologically when you read about kids taking their lives. I saw an 11-year-old in the emergency room not too long ago. The parents found suicide notes in her pencil case. I saw the notes, right? Pictures of it. And this 11-year-old girl wrote about how difficult and hopeless her life was due to the issues she was facing in school and at home. My son is 11. I didn't go and search his pencil case for suicide note, but certainly we had a talk, a father and son talk, right? About the stress he's facing in life and actually why people consider taking their life. Yeah, we have very, very difficult conversations at home, considering the father's a psychiatrist and the mom's a psychologist. Yeah, but it is a wicked problem. We have 37 young people who took their life last year. 2014-2015 was when there was a doubling of figures from 13 to 27. A lot of intervention strategies was devised at that time. Last year there were 37. It represents a tripling. We need to do more, and there's certainly things that we can do in future. But is this a new problem, young people taking their life? It's not. This article came out more than 20 years ago. I'm not sure how many of you remember this. A primary 4 girl took her life because she was unhappy with her schoolwork, unhappy with her mid-year exam results. So this is not a new problem, but it is a rising problem. Another wicked problem, if we think about suicide as a tip of the iceberg, then how about suicide attempts? 10 years ago, this article was published. I was a younger doctor at the time. I thought the numbers were a little bit too low. Since then, there have been reports, there have been published data about the number of suicide attempts in Singapore. If I average them out, it works out to be about 3 suicide attempts a day in the whole of Singapore. I probably see that number in one afternoon in one hospital. So this may be underreported. In 2020, the numbers tripled to almost 3,000. Is it because when suicide was decriminalized, more people decided to take their life or try to take their life? It's not. The data suggests it, but it's not. It's really about how data is being reported. And what's the issue? It's about reporting. So prior to decriminalization, data was collected from the police, and after that, data was collected from the hospital. I work in a hospital that probably sees the most number of suicide attempts. And I can tell you that we are trying very hard to get the doctors to be consistent in their assessment and their reporting. Right now, there are no rules, no regulations or laws stating doctors must report suicide attempt. We don't have a suicide registry, not like some other countries, right? And certainly reporting of suicide does have its consequences. We have patients who tell us not to put their attempt, not to put the diagnosis inside their discharge summary, for example. Imagine families, insurance companies being able to see some of this diagnosis of suicide attempt. There'll be consequences. So it comes down to our teaching, right? What I teach the clinician. When I teach them about self-harm and suicide, I'll tell them to look at intent. Intent is important in how you classify a person's injury, whether it's a self-harm or suicide attempt. You can imagine how difficult this is for the trained and even more so for the untrained. Coming to suicide, we know the science of it. We have got studies, we have got research in Singapore and from around the world. We know the risk factors for suicide. We know the triggers and source of stress that tips people off into considering taking their life. This is a list of stressors for kids or teens, a similar list for adults, and also another list for elderly who face unique problems as well. We also know the protective factors that keeps people from taking their lives. So what's so wicked? We know the science, we know the data. I think the problem is that this is extremely complex. There's an interaction of the risk factors and the lack of protective factors. You add in the stressors and triggers, could be acute, could be chronic. There are cultural factors involved, the person's religion, the spirituality, family factors. Different ones of us are vulnerable for different periods of time in our lives, and plus the availability of means. This makes this entire interaction very, very complex, and hence suicide prevention is really, really challenging. Some clinical issues. It's very difficult to differentiate between people who think about suicide, people who attempt suicide, and people who eventually take their life. We don't have enough hospital bed to hospitalize every single person who has suicidal thoughts. And despite having good medicine to treat depression, we have antipsychotics, we have mood stabilizers, we don't have an anti-suicide pill. We don't have that yet. I wonder whether we'll have that ever. A lot of people may think that suicide has this script, right? You think about, you want to die, you think about suicide, you have a greater intent, you plan your suicide and you take your life, but on the ground it's not like this. It's jumbled up. People can jump from just having a desire to taking their life just like that. There is no pathway, there's no standard script to follow. And it is very important then for us to also note that suicidal acts are often done on impulse, and the crisis that triggers them are just very fleeting, if you remember the list I showed you earlier. And of course, what methods people use depends on what's available. So this is really a question that needs to be asked from a person having a thought about suicide to actually doing the attempt. How much time do we have? Because this is really a time that we can intervene. This was a study done in Houston. They interviewed people who survived their suicide attempt. When this was published, it was alarming. Imagine you have less than 5 minutes to intervene for a quarter of the cases, and for 90%, almost 90% of the people, you only have about 8 hours to have some intervention. They replicated this study in another part of the US. Of course, there's a group on the right hand side you can see that took time to plan, to think about their suicide attempt. But the majority, more than almost half of them, had less than 10 minutes. And this really demonstrates the importance of family members, the importance of caregivers, the importance of friends, and the importance of first responders and suicide crisis hotlines to help. Clinicians may not be able to be so useful for this group that's so impulsive. The other issues that we may face, warning signs. We talk about warning signs of suicide for a long time. You can type into your search engine, Google, warning signs of suicide. And when I did it, there were 28 million results. These are wonderful efforts. When I give talks about suicide, I also teach about warning signs. But warning signs cannot be the only method to pick up who is suicidal. This is an unfortunate event that happened in the US not too long ago. You don't need to read through this. I think the reporter tried to say that there were some warning signs. But does it mean that someone who is bullied in school, who gets into fights in school, who stops attending school is going to end up being a killer? No. Just as people who talk about wanting to die may not end up taking their life, it is very difficult to just use warning signs as a method to identify who will eventually take their life. It is a risk factor, a very important risk factor, but it can't be the only thing that we use. We can prevent suicide by design. It's not just doctors, but design is important. And this comes with it. Why we talk about it is because of means restriction, and I can tell you why it's not so easy in Singapore. Before the 1960s, people killed themselves by hanging. Since the 1980s, jumping from heights is the #1 method because high-rise buildings are freely available in Singapore. How do we restrict people's access to high-rise building? It's difficult. We have done something and it's successful. I put over inverted comma, not because I'm skeptical, but I agree that it's successful. Some of you will remember days gone by where there was no barricade. Now there is, and this helps to prevent a lot of suicide. We have got these barriers at the top of MBS. Well, suicides certainly still happen. We have a 2-meter high screen, but interestingly, I saw a report that says that in Switzerland, the barriers should be 2.5 meters and tilted towards the center. You can see how they use design to stop suicide. Suicide risk assessment is important. A lot of times we think of suicide risk assessment tool as something like this. This is for heart disease. You enter some data, some random data, and it tells you that you have a 13.435% chance probability of having a heart disease. Can we enter suicide risk factors into a tool and it tells us the chance that this person will kill themselves in the next day, the next 1 week? We don't. It's a very imperfect science. A lot of false positive, the tools, there's no perfect tool. It's valuable if patients are truthful. We know that some of them are not. There's many tools in the market. I'll very quickly show you. They have the SET% tool, you have a PHQ-9, you have a CSLRS, which is very commonly used in Singapore. But we must know we cannot just use one single tool in isolation to determine risk level. So what can we do about suicide prevention? There's many measures. I don't have time to go through them all. I'll very briefly talk about the media. Right. The media plays a big role. We know that during this time there were a series of copycat suicide from MRT track and Bedok Reservoir. So media needs to be responsible when they report suicide. Will the person seek help when they read this article? Social media is important. Everyone uses smartphone in Singapore, have access to social media. There are benefits. I am not going to talk about the benefits of social media. All of us here are on social media, I think. But internet comes with risk. YouTube features people who harm themselves. people are bullied online, there is social isolation, there are unregulated content, and these are things which I think as parents, as the community, we need to be aware of. And then what is there a role then? Let's try to harness the role of social media then. What can we do? We cannot stop people from using the internet or using social media, but we can certainly think about how we can harness social media to do suicide prevention work, to talk about suicide and how to help others. So I'll leave it with this slide. It talks about the importance, this poem talks about the importance of building a fence at the top of the hill, then to have a fleet of ambulance down in the valley. And I'll be very happy to answer your questions and have a discussion.